Okay, in this lecture, we're going to take a look at the vocabulary that has to do with pain. Pain is something that we started looking at before when we started looking at some of the questions that a provider might ask. We looked at the different ways that providers conduct a assessment. We looked at, for example, OPQRST. So what we're going to look at and we want to explore in this module and with this lecture is some of the words that are used by patients to describe pain and some of those questions that are asked by providers in order to get information about pain. In this slide, you can see, for example, that part of pain assessment is figuring out when did the pain start. And so here there is an example of a question. Did your pain start suddenly or gradually get worse and worse? So this is a very typical question that you should know how to interpret and that you should know that you will run into. So that's sort of the purpose of today's lecture, is to get used to those words that are used to describe pain by both patients and providers, and that line of questioning that takes place when you are interpreting for a patient who is being assessed for pain. So there's some other ones like, what were you doing when the pain started? For provocation or palliates, what this means is, does anything make the pain better or worse? What makes your pain better or worse? For quality, is your pain sharp or dull? So describing the pain. And I chose to use this information specifically because in this slide, you see that I took it from an EMT training module because it sort of takes those terms that we use internally to describe pain as medical providers, but it is also telling the provider that they should probably use different language when they're speaking with a patient because they are not healthcare professionals. And part of it also is sort of guiding the provider to not limit the patient and to allow the patient to use their own words. So you see here in this section where it says quality, asking is your pain sharp or dull limits the patient to two choices. And then what happens if the pain is neither, or the patient would not describe it in that sense? So then you can see here that the provider is being guided to ask the patient to use their own words to describe the pain. And so a question that you see here is, what words would you use to describe your pain? What does your pain feel like? So these are all really good questions to take a look at while you are studying and going over this lecture. I will also make the PowerPoint available to you so that you can take a moment just to briefly, very quickly see how you're doing with these questions and get used to them. Now, I know that these questions may seem very easy because they're easy for you to understand in English, but I really do want to encourage you to take a minute to actually interpret them out loud, because you can see that even though these are short phrases, you understand the words, you understand the concept, sometimes they can still be tricky to interpret. For example, in the question that says, what does the pain feel like? I'll give you an example for those Spanish-speaking students. ¿Cómo se siente su dolor? That sounds a little funny in Spanish. How does the pain feel? When you phrase that word for word, it doesn't flow as well in the Spanish language. So what I'd like you to do is to take a look at these questions and say them out loud, and then take a moment maybe to write down what are the different ways that you'd be able to interpret this question and that sounds more native to your language of service. Okay, so I just want to make sure that it is clear that this slide is showing you the different ways that providers might ask a question. This slide, for example, it says, if we look at the P for provokes or palliates, it's telling a provider, instead of asking what provokes your pain, use real casual words like what makes your pain better or worse. Okay, this is advice to the provider. There are going to be some providers that are going to keep saying what provokes your pain. And the reason why I'm showing you that is because there will be providers who will continue to ask it in that way. That means that we have to learn to interpret it in that way, because we do not change people's words or phrasing. We don't change register, right?
Pain is your friend, your ally. It will tell you when you are seriously injured. It will keep you awake and angry and remind you to finish the job and get the hell home. But you know the best thing about pain? Oh no! It lets you know you're not dead yet.
All right, so let's get to the main reason for this lecture and talk about pain. So what is pain? Well, the International Association for Study of Pain defines it as an unpleasant sensory and emotional experience arising from actual or potential tissue damage. Okay, so clinically, pain is whatever the person says he or she is experiencing whenever he or she says it's happening. So pain is very much subjective.
In 1995, the British Medical Journal published an astonishing report about a 29-year-old builder. He accidentally jumped onto a 15-centimeter nail, which pierced straight through his steel-toed boot. He was in such agonizing pain that even the smallest movement was unbearable. But when the doctors took off his boot, they faced a surprising sight. The nail had never touched his foot at all.
There is no test that measures pain. There is no test that says this person is feeling 75 milligrams of pain or whatever measure of pain would be. And so what a provider does in order to approach someone's pain, in order to treat someone's pain, is rely on a physical assessment and rely on the information, the subjective information that they receive from a patient. And so it is not our job or the job of the provider to determine the person's pain. It is the job of us as interpreters to say exactly what the patient is saying, whether we agree with it or not, believe it or not, or of the provider to determine whether the patient is telling the truth or not. The provider is going to come up with a plan and treatment to address pain based on what the patient communicates to them. And that's why we are very important in this situation, because that communication cannot take place without us if the patient doesn't speak English. Okay, so let's take a look at some of that vocabulary that we're going to be using when a provider is asking questions to assess a patient's pain. So first, acute pain, okay? And at this time, I want to let you know that acute pain is something that you are going to be tested on. You need to know the definition and how to interpret this term. Acute pain usually comes on suddenly and is caused by something specific. It is sharp in quality, usually doesn't last longer than 6 months. It goes away when there is no longer an underlying cause for the pain. So acute pain, some characteristics are it usually comes on suddenly. It does not last longer than 6 months. Okay, so the kinds of things that cause acute pain include surgery, broken bones, dental work, burns or cuts, labor and childbirth, sprains, things like that. These are things that cause pain, but once they are resolved, the pain goes away. Now, as opposed to chronic pain. So chronic pain is another term that you need to understand and know how to interpret. Chronic pain, on the other hand, worsens and intensifies over time, and it lasts for months, years, or a lifetime. It accompanies disease processes, so usually chronic pain can be caused by things like cancer, HIV, AIDS, arthritis, fibromyalgia, and diabetes. It can also accompany an injury that has not resolved over time. So an injury that has not healed over time can cause chronic pain. Stress from chronic pain can also produce other physical conditions like tense muscles, limited ability to move around, lack of energy, changes in appetite. Now, in this case, what I want you to know is how to interpret chronic pain. You need to know that chronic pain lasts for Chronic pain lasts for months, years, or a lifetime. Typically, chronic pain is defined as pain that lasts more than 3 or 6 months. Usually defined as pain lasting more than 3 to 6 months. So that is a concept that you need to be able to define. Tense muscles, limited ability to move around, a lack of energy, changes in appetite. These are terms that you need to know how to interpret. I'm not going to ask you to define these like I will ask you to define chronic and acute pain, but you do need to know how to interpret these. And this is vocabulary that you can find in your vocabulary for pain descriptors. Chronic pain also causes emotional effects, we said, and that include depression, anger, anxiety, fear of re-injury. This fear could limit your ability to return to work or leisure activities. Okay, that's just a little bit more information about chronic pain, but you do need to know how to interpret depression, anger, and anxiety, as well as re-injury. Okay, as I said before, the assessment of the patient experiencing pain is the most important thing. The provider must thoroughly focus on the patient, listen empathetically, believing and legitimizing the patient's pain, and understanding as much as possible what the patient may be experiencing. And again, we are going to make sure that we are able to convey that with our interpreting protocols and skills. All right, referred pain is pain that is felt at a location other than the site of the painful stimulus. This week, we'll go through a scenario where a patient is describing pain that is associated with cholelithiasis, which is gallstones. And you'll hear the patient say that the pain starts on her side and then goes around to her back and it goes all the way up to her shoulder. And so obviously the gallbladder is not that big and it's not in all of those places. But the pain from the gallbladder, which is the point of origin, is being referred to up all the way up to the shoulder. So the reason for that, what causes referred pain is that the nerves, the sensory nerves that tell us that we have pain in our gallbladder, also tell us that there is pain in other regions. And so when we feel pain in our gallbladder, those nerves are activated and we might feel pain everywhere that those nerves are also connected to. Another example of referred pain is the fact that one of the first symptoms of a heart attack can be jaw pain and pain in the teeth. So in this case, the experience of dentally related pain during a heart attack is a classic example of referred pain, which is pain felt at a site distant from the site of origin. Okay, so referred pain is a term that you should know how to interpret, and you should also know what it means. Neuropathic pain is caused by damage or injury to the nerves that transfer information between the brain and spinal cord from the skin, muscles, and other parts of the body. So the pain is usually described as burning sensation, and the affected areas are sensitive to touch. So sensitive to touch is another phrase that you should know how to say. In your word list, you'll also see the word excruciating. So you should know how to say that. Pins and needles. Now with pins and needles, it's very important that you understand what pins and needles means. Pins and needles in English, what we mean is something like tingling. Tingling similar to what it feels like when your arm falls asleep and it's waking up. So it's coming back, recovering from numbness. Now, the reason why I say that it's very important that you understand this is because we cannot interpret this or translate this word for word, because pins and needles in other languages might mean that a sharper kind of pain, right? Like a poke with a pin and a needle. So we need to be sure that we understand that pins and needles, another way of saying this is tingling sensation. And again, as I said, if we want to define it or explain it, it's the feeling that you get when your foot or your arm fell asleep and it's recovering and you feel sort of, in Spanish we say we feel ants crawling. Okay, and listed here, as you go through this, you can read about common causes of neuropathic pain. But for this lecture and for this module, what we are looking at in this slide is how to say excruciating pain, pins and needles, numbness, burning sensation, and sensitive to touch. Okay, here are some more descriptors for neuropathic pain: burning, shooting, tingling, radiating, lancinating. Another way to say lancinating is piercing or stabbing sensations, or numbness. So again, you will find all of these terms in your vocabulary list and you should know how to interpret them. Okay, another type of pain is somatic pain. And again, you don't necessarily have to know how to say this for this module, but you should know that somatic pain is related to bone and muscles. It's relatively well localized. So localized is another word that you should know how to say. And what this means is that it doesn't necessarily spread to other places of the body, and the pain is felt where the injury is, unlike with referred pain. Somatic pain usually worsens with movement, is tender to pressure over the area. So tender, you should also know how to say. Often accompanied by a dull background aching pain. You should know how to say that as well. And this last point says that sometimes somatic pain can be referred if it is bone pain, but it's not necessarily along a nerve path. The terms used to describe somatic pain include achy, throbbing, or dull. So you should know how to say those terms. Well, localized or localized pain. Somatic pain is a type of pain someone with arthritis might feel, and it's typically treated with non-steroidal anti-inflammatory drugs, which are also referred to as NSAIDs, as well as with muscle relaxants, opioid drugs, if it is more severe. Okay, visceral pain. Visceral pain is usually pain that is caused when there is something going on with organs in the abdomen. Because it is deep pain, a lot of times it's hard to localize it. It's hard to determine where it's starting, where it's coming from. And so the pain may be referred. Descriptors for visceral pain: squeezing, pressure, feeling of pressure, cramping, distension, dull, deep, and stretching. And What we mean by stretching is it feels like something is being pulled and stretched. So now we're going to go over the WILDA approach. The WILDA approach is something similar to OPQRST. It is a template for assessing pain in patients with acute and chronic pain. So it focuses on WILDA, W-I-L-D-A, which is words to describe the pain, intensity, location, duration, aggravating or alleviating factors. And so what we are going to learn to interpret are the terms that are used in order to describe pain, describe the intensity, the location, duration, and aggravating or alleviating factors. Here's a look at the WILDA Pain Assessment Guide. As you can see here, so WILDA, words to describe pain: aching, stabbing, tender, tiring, numb, dull, crampy. So there's some examples there. And then intensity, when a provider is using the WILDA pain assessment tool, they will use the scale of 0 to 10, as you heard me talk about before. So if 0 is no pain and 10 is the worst pain imaginable, what is your pain now? So in this module, you are going to also see this handout. And the reason why I want to give you this handout is because it will have some good information about some of the scales that are used. So with WILDA, the patient is asked about intensity using a 0 to 10 scale, but there are several scales that are used in order to note intensity. And so this is one here, still 0 to 10, but you see that it does sort of have that middle explained. So 0 is no pain, 5 is moderate pain, and 10 is the worst possible pain. And so a provider using this scale might ask, how much does it hurt? Point to a number or face that shows us how much pain you are having. This is called the Wong-Baker Faces Pain Rating Scale. And a lot of times this is used with patients who are nonverbal or with children. But it's also sometimes used when there is no interpreter or anyone who speaks the same language. Location, where is the pain? Duration, is the pain always there? Does the pain come and go? Do you have both types of pain? How long the pain lasts? Not necessarily how long you've had the pain, but questions like, is the pain always there? Does the pain come and go? Do you have both types of pain? And what I want you to notice here is breakthrough pain. That's pain that comes and goes is what we refer to as breakthrough pain. Breakthrough pain is also sometimes defined as pain that gets through even though someone is medicated in order to manage the pain. So it's, for example, someone is given medication that does ease the pain, but they all of a sudden have a flare-up or just a quick, brief eruption of increase of pain, and then it comes back down. That's called breakthrough pain. And then also, breakthrough pain can also refer to someone who's got constant pain, constant moderate pain or mild pain, and then all of a sudden there's a peak, there's a spike in the level of pain that goes up almost to excruciating pain, and then it comes down. Aggravating and alleviating factors. So what makes the pain better? What makes the pain worse? But also, as part of the pain assessment using WILDA, the provider will ask how the pain affects the patient's sleep, appetite, energy, activity, relationships, and mood. So you should also know how to interpret these terms. The provider will also ask if the pain is accompanied by any other symptoms, specifically nausea, vomiting, constipation, itching, sleepiness, confusion, urinary retention, and weakness. as well as gather past medication history. So any medications that you've taken in the past or currently taking,